Thank you, Alain. Thank you very much to the organizing committee for invitation. And yes, I will show you that ECMO has a big role during septic cardiomyopathy. So we know that severe myocardial dysfunction can occur during sepsis. It has been described a long time ago during the 80s, and you have here data coming from Margaret Parker's team showing that, in fact, if you look at the hemodynamic profile of patients dying from refractory septic shock, a significant proportion of them do not exhibit the expected hemodynamic profile during this condition, which is refractory vasoplasia, but have severe myocardial dysfunction and in fact are dying mostly from a cardiogenic shock-like state, what we call now sepsis-induced cardiogenic shock. We are 30 years after those first descriptions, and there are still many questions regarding this disease. Its causes are still imperfectly understood. There are two major hypotheses. The first one is that it's maybe due to the cytokine storm observed during sepsis, and there are experimental data supporting that. And the other main hypothesis is that the high doses of catecholamines received by the patients in septic shock may be responsible for transient myocardial stunning. The incidence also, this is not clear yet. We have only very few data coming from very small studies, but they suggest that it may not be that uncommon. It's not the most common hemodynamic profile, of course, but the incidence is not that rare, maybe at around 10-15% of the patient. And the impact also is not clear, but there are also few data suggesting that it's a devastating condition. In our center, we have been led to implant VA ECMO as end-stage rescue therapy for patients dying with those particular forms of septic shock, and we had good results. We published our first cohort almost 10 years ago now. We had at that time 10 over 14 long-term survivors, patients who could recover very quickly and completely from their myocardial dysfunction and who were reporting good quality of life indexes 1 year after their hospitalization. So we analyzed the role of VA ECMO during sepsis-induced cardiogenic shock recently in a retrospective multi-center collaborative work. We took all patients implanted for this purpose in 5 ECMO centers, 4 in France and Daniel Brody's team in New York. We had 82 patients implanted for this condition, meaning refractory septic shock with severe myocardial dysfunction, defined here by a cardiac index below 3 liters per minute per meter square or left ventricular ejection fraction below 35%. We were really dealing with end-stage rescue therapy here. Patients were really severe at the time of VA ECMO implantation with a very low pre-implantation cardiac index, 1.5 mainly, a huge decrease in left ventricular ejection fraction. They were receiving very high doses of catecholamines with an inotrope score at 279. So the inotrope score, again, is a way to evaluate the cocktail of catecholamines received by the patient, and such an inotrope score represents more or less 8 milligrams per hour of norepinephrine for standard patients. So they were receiving high doses of catecholamines. They had also a very severe lactic acidosis, and they had already profound multiple organ failure reflected by those high SOFA and SAPS-2 scores. And despite this extreme severity, we could confirm an expectedly high survival in those patients regarding their underlying condition. 60% of the patient could survive at 90 days. So the next question was, what would have happened if patients could not have been implanted with an ECMO? And to address this question, we took three large recent septic shock databases. One of them coming from a multi-center randomized trial, the sepsis-PAM study, and we had almost 1,000 patients here. And from those databases, we isolated patients with severe myocardial dysfunction with the same definition as for VA ECMO patients, meaning cardiac index below 3 or left ventricular ejection fraction below 35. And then we took patients with sepsis-induced cardiogenic shock, meaning those patients with severe myocardial dysfunction plus receiving significant doses of catecholamines with an inotrope score above 75 mics, plus exhibiting hyperlactatemia with a lactatemia above 4. And the first result we had here is that this condition is effectively not that infrequent. We had 13% of the patients coming from those databases affected with sepsis-induced cardiogenic shock. Those patients, non-ECMO patients, were less severe at the time of the inclusion. They had less profound decrease in their cardiac index. They had less severe impairment of their left ventricular ejection fraction. They were receiving less catecholamines. They had less severe lactic acidosis and less severe multiple organ failure. But despite this lower severity, we could also confirm catastrophic prognosis. There is maybe somebody who is clicking on something, so the slides are going on by themselves. Anyway, so we despite this lower severity, we had an extremely poor prognosis for those patients. Only 25% of them could finally survive, confirming the devastating prognosis of this condition. So of course, we are dealing here with retrospective data. And the next question was to make groups comparable regarding the underlying severity to assess the role of ECMO. To do that, we weighted patients on a propensity score predicting the risk of mortality of the patient. So you have on the left part of the slide in green all the parameters associated with mortality during septic shock, which were included in the propensity score. And we could have this time comparable groups regarding the severity of myocardial dysfunction, regarding the doses of catecholamines received, and regarding the severity of lactic acidosis and multiple organ failure. And even in those weighted groups, we could confirm that ECMO was associated with a drastic reversal of the prognosis of those patients, with a survival that was very poor in non-ECMO patients, less than 25%, and climbing to up to 60% in patients equipped with VA in red. And in that study, ECMO was dividing the risk of dying by more than 2. We had also here a faster decrease in the catecholamines received by the patients and lactatemia in the ECMO group in red compared to non-ECMO patients in blue. And regarding the myocardial dysfunction, we had the same kind of observations we had in our first cohort, meaning a very rapid and complete recovery of myocardial function in survivors. This is one of the patients in this cohort, Mrs. Yu. When we were called for rescue therapy, she was 52 years old with no previous medical condition. She had been admitted in a small hospital 60 kilometers far from hospital for septic shock due to E. coli pyelonephritis. She had a urethral drainage. She, of course, received antibiotics. And despite that, she developed this particular form of refractory septic shock with very severe myocardial dysfunction. At the time we were called, she was receiving epinephrine at 5 milligrams per hour. She was mechanically ventilated. She had a huge myocardial dysfunction with the left ventricular ejection fraction at 20%, a cardiac index at 1.5. She had very low pulse pressure, as you can see here, severe tachycardia. She had already severe lactic acidosis. She was anuric, receiving renal replacement therapy. She had huge coagulation disorders, and finally a SAPS-2 score at 92, reflecting a severe multiple organ failure. And on the top of that, in fact, she was deteriorating despite all the treatments in place. So we sent our mobile ECMO retrieval team at her bedside, and she was implanted with a peripheral VA. And you have here her echocardiographic study when she, so on the upper part of the slide, it's before ECMO implantations, showing severe biventricular dysfunction. And on the lower part of the slide, when she arrived in our ICU, equipped with a VA, and you can see that hopefully we had a VA because her heart had completely stopped its mechanical activity with no opening of the aortic valve, and in fact also its electrical activity, and this patient was in asystolia when she arrived. We had no clear idea about what would happen for her, but we decided to continue. And what happened is this: she recovered very quickly. Here we are 4 days after ECMO implantation, and she had already recovered enough to allow us to remove the ECMO, and then her heart completely normalized during the follow-up. She had to stay with us for several weeks to recover from her multiple organ failure, and particularly renal insufficiency, but she finally recovered completely and could return back home with a normal life. And this is finally in that cohort, we had very short duration for ECMO runs, 6 days in survivors, but of course quite prolonged ICU stays due to the underlying multiple organ failure at the time of ECMO implantation. And as it is the case for almost all VA ECMO cohorts, we had a significant proportion of patients, almost 1 patient over 2, exhibiting complications directly related to the ECMO system. But finally, evaluating their quality of life 1 year after their admission, we found the same kind of results we had in our first cohort. You have here the SF36 score evaluated quality of life of our patients in red compared to the general French population in blue. And you can see that our patients exhibited a mild impairment in their physical aspects of quality of life, but a highly preserved mental and social status. And both indices were clearly better than those reported by hemodialysis patients. So with those data, we can say that VA ECMO is associated with a drastic reversal of sepsis-induced cardiogenic shock prognosis, allowing 60% long-time survival, complete myocardial recovery, and finally good quality of life indexes. So I think with those data, we have enough to say that VA ECMO is a valuable treatment as rescue therapy. And saying that, it opens a large area of research. The next question, to my point of view, is should we go to an implantation earlier during the time course of the disease to further improve those results? What would be the parameters for that? Here we think that finally the parameters we took for picking the control group in the septic shock databases may be variable, meaning severe myocardial dysfunction plus inotrope score above 75 mics plus lactatemia above 4, because finally we had 75% mortality in those patients. But doing that, we will get out of a true rescue therapy, and we need a randomized trial to analyze that. And that will be the purpose of a trial we are trying to set up here in France, a multi-center randomized trial, which is called the Crescendo trial. And I hope we will be able to set it up shortly. Thank you very much for your attention.
Thank you so much, Nicolas, for doing the pro. ECMO should be used in septic shock patients. And now I have the privilege to set the digital stage to my good friend, Graham Mclaren, working in Singapore. Graham, are you here?
Yes, I'm here. Hello.